Welcome to Medicine in Meadville. I'm Dwayne Kohler from Meadville Medical Center. And every Wednesday we have an educational program for our physicians at Meadville Medical Center that's called 12 o'clock sharp. Special program today, and I think you're going to find this very interesting. Our presenter is Jason Snyder from the Pennsylvania Department of Drug and Alcohol Programs, and his topic is The Last Man Standing, Addiction, Death, and Redemption. So I think you're going to find this very interesting. Stay tuned.
I'm grateful to be able to share my story and my insight and my experience with you, and I am surely grateful for the life I live today. There's professionally no place I'd rather be at this time of my life than, as Cindy said, working for the State Department of Drug and Alcohol Programs as part of Governor Wolf's team and administration as we fight the drug overdose death epidemic. We have in Governor Wolf a leader who is committed to addressing the overdose death epidemic and addiction. And around him we have a team of leaders dedicated to the same cause, none more so than my boss, the Secretary of the Department of Drug and Alcohol Programs, Gary Tennis. When I consider where my life was only 5 years ago, having the opportunity to be here with you today and do the things that I'm doing, I can't help but feel grateful and hopeful to have been put on this path to fulfill a mission. And I really do consider it to be a mission, and that mission for me is to save lives and enable those suffering with the disease of addiction to recover and to get what I have. It's also a mission to carry a message, and that message for me is that addiction can and does affect anyone, and that recovery from the depths of addiction is certainly possible. I believe that in all of the work we are collectively doing to address this crisis, we shouldn't lose sight that the end game is not only saving lives, but enabling lives of recovery from the disease of addiction. And really, who better to enlist in this mission, who better to partner with than you all, the healthcare community. So again, I really appreciate the opportunity to be here today. I want to talk about several things today. I titled my presentation, Last Man Standing, Addiction, Death, and Redemption, because as I thought about what would be the best title, I considered things like stigma and how it prevents recovery from the disease, because I'm going to talk a lot about stigma. But then I thought, that's kind of dry, and if I was going to title the story of my life to this point, this is how I would do it. And so through the story of my life and through some other things, I want to talk to you about addiction and the disease. So what are we going to talk about? First, I want to give you just a very brief description of who the Department of Drug and Alcohol Programs is. I'll then want to talk about what the Wolf administration has called and continues to call the worst public health crisis of our lifetime. I'll tell you about myself, my family, who I am, and in some ways what qualifies me to stand here and talk about these things today. As I mentioned, I want to talk about stigma and the disease of addiction. I want to talk about what Pennsylvania is doing to address it. I also want to talk about how we and the rest of the nation got to this point. And then lastly, I want to just quickly talk about what the healthcare community can do to help us in this battle. First, a little bit about the Department of Drug and Alcohol Programs. As I mentioned earlier, our secretary is Gary Tennis, a very, very passionate leader when it comes to our mission, which is to engage, coordinate, and lead the state's effort to prevent and reduce drug, alcohol, and gambling addiction and abuse. And one of the most important things there is to promote recovery. Our department was formed in 2012. We had always been in existence prior to that as a bureau under the State Department of Health, but Act 50 of 2010 elevated the bureau to a department, and in 2012, when the funding finally was made available, we became a department. We are the smallest department in the state. We have about 75 employees right now, and our budget is a little more than $100 million, which includes federal block grant money as well as state money. We have 3 bureaus within the department. The Bureau of Administration and Program Support, which is really our fiscal manager, data collection, those kinds of things. The Bureau of Quality Assurance for Prevention and Treatment. That bureau handles our licensing. We have more than 700 licensed drug and alcohol treatment providers in the state. So not only does Quality Assurance for Prevention and Treatment license them, it regulates them and ensures that those licensed providers are providing quality treatment. And lastly, the Bureau of Treatment Prevention and Intervention. That bureau really works with our partners throughout the state, especially the single county authorities, the county level drug and alcohol commissions. We have the executive director of the Crawford County Drug and Alcohol Executive Commission with us today, Dave Crow. I really appreciate him being here and all the work he does. Our Bureau of Treatment Prevention and Intervention works with folks like Dave and with the other 47 single county authorities across the state. So I just wanted to let you know who we are, where we're coming from. We are a small agency, as I said, the smallest in the state, and we're up against the biggest healthcare crisis in the state, in the nation, and again, that we have faced in our lifetime. Provide a little bit of context for the epidemic that we're in right now. According to the Pennsylvania Coroner's overdose death report, there were about 2,500 deaths, 2,500 overdose deaths in 2014, and we know that number is low because several counties did not report. That number in 2014 is an average increase of about 20% over 2013 in many counties. Although the final tally isn't in yet for 2015, we know that there are going to be more deaths in 2015, and we have no reason to believe that we will see a decrease this year. So we continue to trend upward in overdose deaths. Interestingly, and I think in some ways going against what we stereotypically believe to be the person who dies from drug overdose is, the slight majority of deaths in 2014 were in the 45 to 50-year-old age range. Typical decedent is a white male in that age range who is single. Across the board, deaths among 21 to 30-year-olds, 31 to 40-year-olds, and 51 to 60-year-olds are nearly equal. They each represent about 22 to 23% of the deaths in 14. According to this number, this 2,500 number in Pennsylvania, that means at least 7 Pennsylvanians die every day from drug overdose, and we know again that that's probably low. The real number is probably 8, 9, maybe even 10. We know the more people die in this state and nationally than from drug overdose than they do as a result of automobile accidents. Drug overdose deaths have become the #1 accidental cause of death in this state and in this country. And we also know that in this state and in this country, addiction affects 1 in 4 families. A little more context for you. I want to get a little more specific on Crawford County. And again, this information comes from the Pennsylvania Coroners Pennsylvania State Coroners Association overdose death report. In 2014, 16 overdose deaths in Crawford County, 12 male, 4 female, which is in keeping with what we know to be the majority sex for overdose deaths. Interestingly, mirroring really the rest of the state, we have in Crawford County 4 deaths in the 20 to 30 age range, 4 in the 31 to 40, 4 in the 51 to 60, 2 in the 41 to 50, and as you can see on the PowerPoint slide, 2 in the older than 61 years old age range. Interestingly, too, right now we are, as I've said several times already, in the midst of the worst overdose death epidemic that we have ever seen. And heroin is rightly so fingered as a primary driver of this epidemic. But when and if you read the coroner's report, and I would recommend that if you have a minute, you flip through it. It's a pretty interesting piece of work. Most deaths are the result of multiple prescription drugs, either alone or with the addition of heroin or cocaine to a lesser degree. So we hear a lot about heroin. We hear a lot about young folks who are dying from heroin overdose deaths. Our focus has been on those folks, and as I say, rightfully so. But we have to look a little deeper, dig a little deeper, and understand that it's not just the 20-something male, and it's not just heroin. It's prescription drugs. It's powerful opioids, narcotics, narcotic pain prescriptions. It's benzodiazepines. It's a whole range of other drugs. In fact, I saw some numbers for Westmoreland County, which reported its 2015 numbers. There were 126 deaths in Westmoreland County in 2015. Just under half of those were not heroin related. Said another way, just a little more than half were heroin. So the reality is drug overdose deaths are being caused by a broad range of different drugs. How do we want to handle questions, Cindy? Do we want to wait till the end? I saw a question back here.
That's up to you, Jason.
Why don't we wait until the end if that would work? I appreciate that. So again, just some context to really illustrate the crisis that we find ourselves in. A minute ago I told you that part of my mission is to help people get what I have, and although I do have a fantastic job today as Policy and Communications Director for the Department of Drug and Alcohol Programs, I don't necessarily only mean help those with the disease of addiction to get a good job in the material things that I have managed to get in my lifetime. I mean internal peace, joy, freedom from the obsession to use drugs and the compulsive use of drugs. I mean faith in myself, faith in the tools that I have found to successfully manage my life, and I mean hope, because my life had truly become hopeless, even though, as I'll share with you, much of it, on the surface anyway, seemed like a storybook. For many years it was anything but that. I think this is a good time then for me to segue into the story of my family, illustrate for you the numbers that we just talked about, to attempt to translate data into real life, and to attempt to demonstrate that for each of these deaths, whether it's the 16 in Crawford County, the 2,500 across the state, or the 47,000 that died of drug overdose deaths nationally in 2014, to really demonstrate that there really is a tragic story to be told behind each of these. And that the characters, at least in the story that I will tell you, were born of love, were raised in love, and were part of the fabric, even at their very worst, of a family, of a good family, a family that provided for all of our needs and all of our wants. This is a picture of, obviously, me quite a few years ago. Well, not that many, but I'll get to that. My mother, my two brothers. I couldn't find a picture that had my dad in it as well, although he is certainly still an integral part of my life and my mother's life. I am a lifelong Pennsylvanian. I was raised the oldest of three boys in Cambria County, so just a little southeast of here. Well, maybe a little more than just a little, but southeast of here. Raised by parents who are still married today. In fact, they recently celebrated their 44th wedding anniversary. My dad was a hard-working man his whole life. He was a lineman for an electric company in Johnstown, Pennsylvania. Climbed telephone poles, worked out of bucket trucks, eventually moved into management, survived several buyouts of the electric company for which he worked, survived a lost job to successfully retire this past May at the age of 65. My dad was a Little League coach for many, many years, coached all three of his boys. He took us hunting. One of my absolute greatest joys today is spending time with my dad in the mountains of Potter County, just east of here, where we have a hunting camp. My dad didn't drink. He certainly didn't use drugs. And as I mentioned, he provided a good life for us, everything that we needed and really most of the things we wanted. My mother was a stay-at-home mother. She was very active in the PTA, never missed open house when she had an opportunity to talk to our teachers about how we were doing. She always made sure we studied. I remember in elementary and middle school actually dreading the day before a test because my mother knew that I had a test and she'd be quizzing me from the textbook, and if I didn't pass muster I had to go back in the bedroom and keep studying, come back out. So I tell you all of these things to illustrate that my parents were very involved in our lives. And in fact, our life was, by all measures, prototypical middle-class, blue-collar life. Which is why when my brother Todd, the second one from the left on this slide in the red sweatshirt, which is why when he at age 28 died of a heroin overdose, we were stunned. We had watched Todd's life spiral out of control for many years. And we knew it was bad. My parents did everything they could for him. Hired attorneys when he was arrested, tried to get him to go to treatment. I think we knew at the time that death was a possibility, but I also think we thought that it wouldn't happen to us. I mean, it just doesn't happen to families like ours. Inside, I think we held on to hope that somehow Todd was going to pull out of this. That it was somehow going to get better. Like I said, we had the possibility of death in the back of our minds, but we pushed it away and hoped, and again, didn't really think that this would happen to us. But it did. In the early morning hours of January 24th, 2005, I got a call from Todd's girlfriend. Todd and his girlfriend at the time lived just a mile or two up the road from me. And she told me she couldn't get Todd up. And I told her to call 911 and that I would be right there. I was there in minutes. Found him dead on the kitchen floor. He was blue. I knew he was dead. Paramedics came and confirmed that. A little more than 11 years have passed since that morning, and although the image of my brother laying dead on a kitchen floor of a house he rented is not as vivid to me as it once was, I still regularly see that image when I think about Todd. So with that, I had to then make the most difficult phone call that I've ever made in my life. I stepped out on the front porch, frigid January morning, and called my parents. My dad answered the phone. I don't know, it was probably 5 in the morning. And of course, nobody calls anybody at 5 in the morning unless it's bad news. My dad answered the phone, and I told him that Todd had overdosed, and he asked me whether he was okay. And I said no, and my answer set off a chain reaction of wailing that I could hear from the other end, from the telephone. First my dad wailing that Todd was dead, my mother laying in bed next to him beginning to wail, and lastly I could hear my youngest brother, who was living at home at the time, Josh, coming out of his bedroom and coming into earshot, wailing about the death of his brother. I could hear all of this on the other end of the phone and do nothing, say nothing, simply listen. I didn't think it could happen to us. I don't think my family thought it would happen to us. Families like ours did not lose a son and a brother to drug overdose. It was shocking, despite what we had seen happening. So when my brother Josh, the one on the left of the photo in the black sweatshirt, when Josh at age 25 died of a drug overdose a little more than 2.5 years after Todd's death, it was surreal. This time around it was my mother calling me while I got ready for work to tell me that Josh was dead. After I hung the phone up, I remember falling to my knees in disbelief. This family that my parents, like most parents I suppose, had invested so much in and had such high hopes for, was dismantled. I remember my dad at the time of Josh's death crying to me and asking, what are we going to do? To that I had no answer as well. Josh died on September 14th of 2007. In fact, today, March 9th, would be his 34th birthday. Josh's son, Peyton, was born on November 14th, 2007, exactly 2 months after the death of his dad. So Peyton obviously will never see his father alive. And although Todd left behind a 5-year-old daughter at the time of his death, and although she lost her dad and her mother has been in active addiction for most of Trinity's life, she is in the final months of her senior year of high school, getting ready to go to Indiana University of Pennsylvania. So very proud of Trinity for what she's done, what she's been able to overcome. But the fact remains that I fear for her and I fear for my nephew for what may be to come. So with my brother's deaths, I was essentially the last man standing. As I mentioned, I was raised the oldest of the 3 boys. So that made it that much more difficult for me to tell my parents, who really had me on a pedestal in late 2011, that I was entering inpatient rehab for an addiction to prescription pain medication, namely oxycodone and oxymorphone. Can't even imagine the fear that ran through them and is likely still with them today, hearing from their last living son that he is potentially on the verge of where his 2 brothers ended up. But I believe my parents have hope today, and they have some sense of peace, knowing that today I am a person in recovery from the disease of addiction, and what that means for me is that I have not had a drink or a drug in little more than 4 years. When I was in what those who are in recovery call our active addiction, and even in those early days of sobriety, I could not imagine 4 days of abstinence, let alone 4 years. It's been a very, very wonderful, beautiful 4 years for me, and I'll talk more about that a little later. It was less than a year ago that I decided to publicly talk about my addiction and my recovery. I chose to tell my story in large part to address the stigma that surrounds the disease of addiction. For as many years as I used drugs and alcohol, I never accepted or faced the fact that my use was getting progressively worse or that I was addicted. During those years, as my disease was progressing, I watched my brother's addictions progress right along with mine, but I was different than them. I didn't use a needle. I was fortunate to not have gotten to that point, though I am not so foolish or naive to believe that it can't happen to me even today if I am not vigilant in doing the things that I have to do on a daily basis to stay in recovery. Unlike my brothers, I did not get arrested. I managed to keep my job through all of my years of drug and alcohol use and addiction. But my life was still unmanageable, and it was controlled by drugs. I had built a life that on the surface seemed normal. It even had the hallmarks of success, even though I was crumbling inside. And at the end, the house of cards that my life had become, built on lies to others and myself, was crumbling too. Still, I could not let anyone know about the problem I had. I did a pretty good job fooling most of the people most of the time, at least I thought. And at the time I thought people thought I was something, but certainly not an addict. I was married at the time. I owned a home. I had a job where I carried the title vice president and eventually senior vice president, and I interacted with clients regularly, advising them on public relations and communication strategies, all the while, even at times in face-to-face interactions with them, using drugs and being high on prescription pain medication. I took some nice vacations. I had a few things, right? I had some new vehicles. For me to admit to addiction meant that I would be dismantled. So for a long time I continued to lie to myself, tell myself that this would be the last one, this would be the last time, then I was going to stop. But I couldn't. And I was unwilling to seek help because of what others would think. I was convincing myself that I could handle this, that I could change on my own, but the reality is I was in denial. I rationalized my behavior and my drug use. I justified it. My pattern had me using for 3 or 4 straight days. And then when I was out of drugs or couldn't find what I needed, I typically had a supply of Suboxone, buprenorphine, which I got from the street to help me manage the withdrawal. In the worst of times, I had nothing. And so I withdrew and became sick until I could use again. During that time of my worst active addiction, every day, whether I was high or I was sick, my thoughts were consumed by oxycodone and how I could get it and how I could continue paying for it. And I was paying a premium for it on the street. Many of the stories we hear today, and I'll talk more about this later, about what the state's doing to address the idea of doctor shopping. Many of the stories we hear today about people addicted to prescription pain medications are punctuated by this idea that they're doctor shopping, and there's no doubt it goes on. I'm sure you folks have very well experienced it yourself. I was not doing that. I was buying mine on the street, and I was paying a premium for them. Believe me, using credit cards for cash, using lines of credit for cash, having credit card statements mailed to addresses where my wife wouldn't see them, keeping things hidden. The regular withdrawal that I went through was terrible, as much physically as it was mentally. It's a terrible, hopeless feeling to wake up in the morning and think death would be preferable to the life I was living. But to feel better, to function, I had to use. Then as I used and felt better, I'd tell myself I was done. When I managed to get through a few days of withdrawal and started to feel a little better, or after a few days of using only Suboxone, I then convinced myself that I was fine and that I could keep using. And that cycle just continued. Besides, in my mind, if I was an addict, I would be and look like one of those people we often read about in the paper. One of the stereotypical addicts, a criminal, homeless, dirty, no self-control, a loser. Any respect I thought I had from peers and colleagues would be gone. I would forever be looked at differently. And I thought all of these things about people with addiction, even though I had 2 brothers die from the disease. I knew my brothers, absent the addiction, were not those stereotypes. I knew the good boys they were. Still, I could not be one of them. So, by the grace of God and a woman whose name I cannot remember today, I was helped into residential drug treatment. Ironically, one of the drug dealers from whom I was buying my prescription pain pills gave me her name. All I know about her is that she was in recovery. She worked the streets to make assessments and to get people into treatment. I eventually called her. She came to my home, gave me an assessment, determined the level of treatment I would need, and then she worked the phones diligently. In 2 days, I was in a detox bed, having been transported about 3 hours away to the facility, by the facility, and that really was the turning point in my life. Although the details of my addiction differ from those of my brothers, the way I look at it is we had the disease of addiction in common. And although the details of my active addiction differ from the details of many of the people I know in recovery today from the disease, we have 2 things in common: our disease and our recovery. And with those who are still in active addiction, there's only one difference as I look at it, and that is that I am in recovery and they are not. For me to look at this any other way, as if I'm better than or worse than others, is a slippery slope for me. Although some are sicker than others, there's no question about that. Just like any disease, those in active addiction share the same thought patterns that I had and that I can still have today, although in different manifestations. People who are in active addiction have an obsession to use drugs. They compulsively use drugs. They are unable to stop using drugs despite all the consequences, even with the greatest willpower and most sincere desire. As I said, my life was falling apart. My marriage was on the rocks. My addiction eventually cost me my marriage, cost me the home I lived in with my then wife. It cost me relationships I had built over many, many years. And I knew all of that was a possibility. And I kept using. I want to talk now a little bit more about stigma. Of the many things I believe tear my mother apart to this day, 11 years after the death of Todd's death and more than 8 years after Josh's, is that she knows there are people out there in her own community who say her sons got what they deserved. That they were junkies who chose to use drugs despite knowing the consequences. And there are a fair number of people out there who certainly would say that their lives weren't worth saving. All you need to do is read the comments on any online news story about efforts to save people with the disease of addiction, and you'll see what I mean. Like this one here on this slide. I think, referencing the naloxone program, which I'll talk about in a minute, I think it is the dumbest waste of time and money to help these druggies survive their own stupidity. We need to let them overdose and die so we have less bums to live with. That's what we're up against. And my mother knows there are people out there who think that very thing about her sons. Some, as this fool would say that people with the disease of addiction are throwaways. Yes, my brothers and I used despite the consequences, despite knowing the consequences, and that is a hallmark of the disease of addiction. So because I know how it hurts my mother, and because I knew the kind of boys my brothers were absent addiction, and because I identify with those in the throes of addiction, I've chosen to tell my story. Because in the fight against stigma, it will take a lot more than simply referring to addiction as a disease. William White has worked in the addictions field since 1969, and he has co-authored or authored more than 400 articles, monographs, research reports, book chapters, 18 books. He wrote that today's recovery movement battle cry is not that addiction is a disease or that treatment works, even though we know both of those statements are true, but that recovery is a reality in the lives of millions of individuals and families all across America. This new movement calls on recovering people to step forward to offer themselves as living proof of the hope for sustained recovery from addiction. But you can see why many people would choose not to, because this is the stigma that we face every day and that continues to be perpetuated by a sensational media that relishes at the opportunity to put that picture in a newspaper. That every time, even the DEA in its overdose death report, of course this is an organization that has a crime and punishment mentality, but to see images like this and this on the cover of an overdose death report continues to perpetuate the stigma. Every time we hear about drug addiction today, we see a needle and a spoon. And think back to what I said earlier. Not everybody who's dying of a drug overdose is dying with a needle and a spoon. They're dying with prescription drugs prescribed to them by the healthcare community. So we have a lot of work to do when it comes to stigma. Stigma keeps people with addiction sick because of shame and guilt. And we cannot fulfill a mission of saving lives and enabling recovery if we, as a society, block access to treatment with stigma. I want to talk a little bit about how we got to this point. In 1979, a Dr. Herschel Jick at Boston University School of Medicine pulled data from a database that today is known as the Boston collaborative drug surveillance program. That program includes millions of patients' hospital records. The data he pulled in '79 showed that of nearly 12,000 patients treated with opiates while in a hospital, only 4 became addicted. A graduate student named Jane Porter drafted this information into a letter to the editor of the New England Journal of Medicine. Depending upon the interpretation of the letter, it demonstrated that less than 1% of patients treated with opioids became addicted. The letter came to be known simply as the Porter-Jick letter, and it was published in '80. That same year, among changing attitudes toward the prescribing of opioid pain medication, the World Health Organization claimed freedom from pain as a universal human right. If a patient said he was in pain, doctors should believe him and prescribe accordingly. From that point, between 1980 and 2011, worldwide morphine consumption increased 30-fold. And a lot of this we're talking about in terms of treating cancer patients, and it's righteous. But as we move through those years, as is well documented, attitudes toward prescribing powerful narcotics to treat chronic pain changed. Wealthiest countries in the world, representing 20% of the world's population during that 1980 to 2011 time frame, consumed more than 90% of that morphine, interestingly. In 1986, as more pain specialists emerged under the view that not only was it acceptable to treat pain with opioids, but that it was cruel not to give opioids to people in pain, 2 doctors, Russell Portnoy and Kathy Foley, published a paper in the journal Pain. Based on a review of 38 of their cancer patients with chronic pain who used opiates, only 2 became addicted, according to them. And those 2 had histories of addiction. The paper concluded that opiates themselves were not inherently addictive, that a lot depended on the person taking them. Cited among the quote-unquote research supporting their paper was the 1980 letter to the editor written by Jane Porter and Dr. Jick. From that point, the idea that opioids could be prescribed to treat chronic pain grew. And over the next few years, that letter to the editor would come to be referenced simply as a landmark study. Headlines morphed from that letter to the editor to read, "Addiction rare in patients treated with narcotics." In all of this, the fact that these patients Jick described were hospitalized and not followed post-discharge was omitted. The pro-opioid movement seized on it, and none more effectively or deadlier than Purdue Pharma, which in 1996 produced OxyContin. Based on that landmark study of hospitalized patients, Purdue aggressively and misleadingly marketed OxyContin. I'll leave you with a couple of quick facts about this because I could go on and on about this. It's a fascinating story. There's a book called Dreamland written by an author by the name of Sam Quinones. It's a very easy read. It's a great read. It's a fascinating look at how we got to this point over the last 20 to 25 years of aggressive and misleading marketing, which led to overprescribing, which led to heroin. In '96, the first year OxyContin was produced, under an increased sales quota for salespeople to make bonus for selling OxyContin, Purdue paid out $1 million in bonuses. That was '96. 5 years later, Purdue paid out $40 million in bonuses tied to OxyContin sales. So I give you that as context to say this is what their strategy was: flood the market with OxyContin. And as you see here, in '07, they agreed to a $634 million settlement, really a drop in the bucket for a Purdue to a fine, pled guilty for defrauding and misleading the public. So it's a fascinating story. It really is. So I want to talk now a little bit about what we're doing. And we're doing a lot. In collaboration with the Department of Health, the Department of Drug and Alcohol Programs has created several prescribing guidelines. These were developed in collaboration with the Pennsylvania Medical Society at the leadership of the Physician General as well as others in the Department of Health. At this point, there are 6 guidelines that have been created. You can see them here on the slide. I don't need to read them to you, but I would suggest, if you're interested, if you go to the Department of Health website at health.pa.gov, you can find all 6 of the guidelines. And really what the guidelines are intended to do is provide suggested key practices for healthcare providers to incorporate into their care when they're using or considering the use of opioids for the treatment of pain. In addition, again, working with the Pennsylvania Medical Society, the Department of Health, and some other key partners, we are creating continuing medical education to help healthcare teams better understand and provide to them information they need to know about opioid abuse. Naloxone, I mentioned earlier, is the topic of one of those CMEs, the prescribing guidelines. ABC MAP, which is the state's prescription drug monitoring program, which will be used again to identify doctor shoppers, for lack of a better description, not to punish these folks, but in an effort to help them get into treatment, to identify those who are having substance use issues and get them into treatment. And we're also working on a warm handoff policy. The warm handoff policy goes hand in hand with the naloxone effort, and I'll get to that in just a minute. I think relative to all the folks in here, I wanted to mention one other thing that we're doing, and maybe we're a little late. Maybe medical schools are a little late, but better late than never. In collaboration with Pennsylvania's medical school deans, the Department of Health, Department of Drug and Alcohol Programs is working with those schools to see how curriculum can be created and made part of that curriculum to properly train doctors in training about responsible pain prescribing, how to identify those who are exhibiting drug-seeking behaviors, and really how to help them get into treatment, not to simply kick them to the curb. Naloxone, I've mentioned that several times. I'm sure you all know what naloxone is. Brand name Narcan safely reverses an opioid overdose. Over the last nearly year and a half, it's been the department's priority to get naloxone into the hands of first responders, most especially the police. Across the state in that time, about 300 municipal police departments have come on board to carry naloxone. We know that police are first on the scene of an overdose about 70% of the time, so it's critical that they carry naloxone. Over the last little more than a year, police have reversed at least 650 overdoses with naloxone, so we know that it's working. That number is probably a little low, like much of the reporting that we are asking folks to do. It is not mandated, but we know that it's working. Naloxone is saving lives, but we also know that naloxone is just a tool to save lives. It is not a treatment tool. It is a life-saving tool. So what do we do when we reverse somebody? Working with our county-level drug and alcohol commissions, we have asked them to create what we're calling a warm handoff policy that would take an overdose survivor from the emergency room directly to a treatment bed. It's a heavy lift. There's a lot involved in it. We have a bed shortage in this state, not only residential treatment beds, but detox beds. So when we start to work hard on one piece of this puzzle, another piece kind of rears its head. So we have asked the county level drug and alcohol folks to get creative, and we understand the challenges in front of them. Some of the other things we're doing, we have put in collaboration with the Attorney General's office, drug take-back boxes across the state. There are more than 400 of them in communities. I believe there are 6 drug take-back boxes in Crawford County. These are secure boxes located at police departments throughout a county where families, community members can get rid of safely unused, unwanted prescription drugs. In 2015, the state took back about 40,000 pounds of prescription drugs, which is about 22 tons. We estimate that about a quarter of those were opioids. Through a partnership with the National Guard, those prescription drugs are then picked up and incinerated. So I wanted to begin to wrap up by suggesting some things that you all can do to help us. People with the disease of addiction need compassion. And believe me, I understand what a difficult population this is and what a difficult disease it is to treat. If any of you folks work in the ER, I'm sure you have horror stories, both of people coming in who have overdosed, those coming in exhibiting drug-seeking behavior. I understand the challenge in the population. Nonetheless, I also understand the stories behind these folks and how they've gotten to this place. You know, right now we have to stop the deaths. We have to save lives, but as I mentioned, that's only a first step. We need to enable lives of recovery. And the way you folks can help us is just a few simple things. Read and use the prescribing guidelines. You're the experts. I'm not here to tell you how to prescribe opioids. I'm pretty good at using them, but I don't know anything about prescribing them. These are suggested guidelines. Take a look at them. And if you have feedback on them, let us know. I will point you to the right folks in the Department of Health, in the Department of Drug and Alcohol programs, because we need to work with the healthcare community. I think a lot of people assume that because you all are in healthcare that you understand how the disease of addiction affects the person suffering from it. And many of you may well, but many of you may not. And I would ask that understand my story and the stories of those people who are in the throes of the disease of addiction. Help them. The healthcare community can be a bridge to treatment and recovery. We are trying through some other initiatives we have underway to provide education to the healthcare community, as I mentioned, through some of the CMEs, to help physicians, help healthcare providers better understand and identify how to help a person rather than simply kicking them out of the practice. And perhaps most importantly would be to work with local treatment providers and your local county level drug and alcohol commissions. And again, for Crawford County, that's the Crawford County Drug and Alcohol Executive Commission. Dave Crow, I know would, I don't want to speak on his behalf, but I know he would be most appreciative and excited to work and partner with you all in whatever way necessary. The Department of Drug and Alcohol programs would as well. As I was talking to Cindy prior to the presentation, I told her that the Physician General, Rachel Levine, that my secretary, Gary Tennis, any number of people in Governor Wolf's administration will do whatever it takes, will come here, work with you, present to you, because this is a top priority of the Wolf administration. These are just some simple suggestions. If you know of ways that you can help us, I'd love to hear them as well. As I said, we must enable lives of recovery. For me to get the life of recovery that I have today, I had to first acknowledge my addiction and get honest with my family and my employer, and it took me a while to do that because of stigma. I had to accept that things were not going to get better if I didn't do something, and as I'm sure many of you know, and as I know well from my experience, it takes many people with addiction a long time to realize this, and unfortunately many never do. I had to be willing to enter inpatient treatment, even though it meant my secret would no longer be secret, even though I believed I was risking everything. But the truth is, if I didn't do the things I had done to get help, I likely would have lost everything, possibly including my life. For me today, doing whatever is necessary to maintain my recovery means I commit about 20 hours per month to 12-step recovery meetings, not to mention the things I do daily to continue working on myself to change my old ways of thinking. Because while there is an obsession to use drugs and there is a compulsive use of drugs, there is a big, big spiritual and thinking component to the disease of addiction. That for me today is the thing that I need to most address on a daily basis, because no pill, no film, no liquid alone can change my way of thinking. It takes hard work, but it's really a small price for me to pay to live the life I do today, to have the job I have, to have the opportunities I have, to live a life unafraid, because I was consumed by fear, to have good health and maintain my health, to have good people in my life, good relationships with my parents, my girlfriend. I picked up a guitar at age 40, picked up a fly fishing rod at age 41, spent a lot of time in the mountains. I read, I learn, I go to the gym. My life is full of good things. These kinds of things are available to everyone suffering from the disease of addiction. We have a lot of work to do, but we have the ability to help provide these things. I'm privileged to know many people in recovery from the disease of addiction. In fact, I am but one of 23 million people living in this country today in recovery from the disease of addiction. As I said at the beginning, part of my mission is to carry the message that anybody can become addicted. My family was and is a good family. We never believed addiction could affect us, let alone kill two of us. I never believed I could become addicted, yet it slowly, progressively crept up on me. But as I hope my story demonstrates, recovery from addiction is possible. There surely is hope for individuals and families suffering from the disease, and the healthcare providers in this room must be our partners. You can be a bridge to treatment and recovery. We know that recovery is possible, but we need your help. And surely, who better, really, than you all to help us in this monumental challenge? Who better than the healthcare community? I appreciate your time. I appreciate the opportunity to be here.
Well, Jason, thanks for that talk. That was really something. I appreciate you coming out to Meadville Medical Center to give that talk today. Also, thanks to the folks at home for joining us, and we will talk to you next time.